pass the mic? You know, we don't have a mic, but can we pretend? Over to Dr. Janie Merkel. I'm going to call you Dr. Janie Merkel, but Janie, to introduce our next segment. Thanks, Janie.
My pleasure. Welcome back. I'm not seeing Dr. Rawat here on the screen. So welcome back from break. This is our first fireside chat here for Innovation to Impact. And I'm really excited for Dr. Rawat to tell us about her experience as a founder of Openbeds, but I don't believe she's here yet. So, oh, there you are. Great. Hello. Please unmute yourself.
Yes. Hi. Sorry.
Hi. No. Thank you so much for joining us today on our first day of the third cohort of Innovation to Impact, our first virtual day. We've had our group here since noon today and have been really in preparation for our conversation. Had a lot of conversations around, you know, identifying opportunities and customer discovery. So I'd love to introduce you, but I first need to know how to correctly pronounce your name.
So Nishi, it's Rawat, but feel free to call me Rawat. It's fine.
Okay.
Yeah.
So Nishi Rawat, she's the founder and CEO of Openbeds. Since September 2018, this was acquired by Appriss Health, so she's now the senior vice president there. But Nishi is double certified in both critical care and emergency medicine and faculty at Johns Hopkins University School of Medicine. So she's both a physician and a co-founder, and really was the person and the driving force around Openbeds. And so as part of this fireside chat, we would love to learn, you know, about your journey and what was the genesis of Openbeds that suggested to you that there was a need there.
Yeah, sure. So, you know, as you mentioned, I'm a critical care physician, also Canadian, and that's relevant just because after I finished my residency and fellowship in Baltimore at Johns Hopkins, in order to, and some of you may be familiar with this process, you know, get an H-1B. To get my green card to stay in the U.S., I ended up working in underserved areas, rural hospitals, critical access hospitals. And, you know, a lot of these hospitals had intensive care units, right? But they didn't necessarily have the services, the expertise to deal with really sick patients. And so I was probably transferring out 25% of the patients that I was seeing to the tertiary and quaternary care centers in the region. Really stressful. Not all was able to get people out, and you know, you wonder whether they would have survived if you got them out in time to get the care that they needed, whatever it may have been. And so I set out to solve that problem, make it easier to transfer patients from smaller hospitals to tertiary and quaternary care hospitals, specifically critically ill patients. And started to work on this within Hopkins, then, you know, took it out of Hopkins. It was clear that I wasn't going to be able to move forward at the time from within academia. I know things have changed now, and I'm sure we'll touch on that a little bit later. But that was really the genesis of it all. We always knew that there was an opportunity in behavioral health. Around that time, I pitched somewhere. I wasn't, you know, I didn't like pitching for the sake of pitching. I really avoided all of these startup events, but I was convinced to do this, and I think we won, and then we ended up presenting at a global meeting in DC, And NIDA was actually in the audience, and they approached me afterward and said, we definitely need a solution like this for substance use disorder treatment. We're in the midst of the opioid epidemic. And in any event, that's what got us thinking and got us to pivot and focus on behavioral health, really because we didn't have the bandwidth at the time to pursue both use cases. Yeah, and you know what's interesting is that what's sad actually is that that original use case, not being able to get people out to tertiary and quaternary care services when they were at death's door, it's still a problem that's prevalent. You're probably reading about it every day. You've got these smaller hospitals with people suffering from COVID on ventilators, and they just don't have the expertise to deal with these patients in multi-system organ failure or, you know, ARDS, significant respiratory failure, and they're trying to get them out. And actually, there was an article in the New York Times 2 days ago, an editorial about how this inability to transfer people is contributing to disparities in care. And so you've got minorities that are disproportionately dying from COVID, and this is in part due to the fact that they're not getting the quality of care that they need and deserve. So it's hard for me to you know, to say, I didn't solve that problem. That was the problem I was trying to, you know, solve a couple of years back, and it's still a problem now. But we'll get there. Yeah.
Well, and you're learning so much in the substance use disorder space, right? So, you know, that's something to bring with you. And so how you then map, you know, that need with critical care needs, you might develop something differently, but you're getting all this knowledge and understanding of the system and the complex payer provider market, and, you know, so many different pieces that I think you could bring to that problem in the future.
Well, yeah, and not even in the future. We're doing it now. So what's really nice is that we've circled back to our roots. And so when COVID hit back in March, we said, look, we can develop a critical resource tracker, right, to track services, beds, PPE, personnel, right, all of these critical resources. And so long story short, we dusted off that old product, we retooled it, and now it's implemented across 124 hospitals in North Carolina, right? So we're improving access to ICU beds, med-surg beds there, along with you know, tracking and reporting out on vital resources. And so, yeah, all this to say that, you know, we've come full circle. So we're doing something about it. Yeah.
And were you able to bootstrap off of the infrastructure and the behavioral health field?
Yeah, so again, you know, we came full circle. So we initially built the product back in 2015 for this ICU bed use case, and then built out the product eventually for a mental health and substance use disorder treatment to improve access to treatment. And then, like I said, we've come full circle now and gone back. Well, we've got another version of the product now called the Critical Resource Tracker that tracks these critical resources for the pandemic and other emergencies. Yeah.
Fantastic.
Yeah.
So I wanted to go back to this transition. When you were approached by NIDA, you know, you put yourself out there as a founder and you're at a pitch fest, and NIDA said, we have this really big issue in the substance use disorder space. On the Openbeds website, it describes how you met with over 150 providers, administrators, and government officials. And we were just learning in the previous session with a School of Management entrepreneurial leader, Kyle Jensen, about the customer discovery process. Can you tell us, you know, a bit about how that worked for you, and, you know, what you learned in that process that you didn't know before, and more about how you got to 150?
Yeah, so I mean, when NIDA approached us, my first answer was no, we're not going to do this. I mean, what they wanted us to do was apply for a small business innovation research grant. And, you know, having applied for several grants myself within academia, there was no way that our small team of 5 people was going to be able to pull off, you know, a 100 and something page SBIR grant, you know, phase 1, phase 2 in 2 months, right? There's no way. I thought of it as a distraction, but NIDA, to their credit, they pushed really hard, and ended up convincing us to do it and we did it. And we ended up, it's $1.8 million that we ended up getting, which is a significant amount of money. And that's what made us really, really pivot. Now, I didn't know anything about behavioral health at the time. Our team didn't know anything about behavioral health. So we had to meet with people in the industry, right? We had to meet with treatment providers. We had to meet with social workers, case managers within hospitals, people who work within the criminal justice system, the drug courts, right? We needed to understand their challenges to find the opportunity. And 150 was the right number. I think we were part of the I2I program, and I think that's why we ended up doing, I can't remember why it was 150. I think it's because we had to as part of the I2I program. But I do think that I felt like after about 30-ish conversations, to be honest, I started to hear the same things. 30 conversations with, let's say, hospital people, or 30 conversations with treatment providers, right?
And you had so many different groups.
Yeah, that's right. So you have to, yeah. But it's interesting because when you look at, some of you may be qualitative researchers, right? And I think 30 is about the number where you start to hear the same things over and over again. So yeah, maybe it was 5 different groups of people, 30 conversations. Yeah, that sounds about right.
Yeah. So when at what point did you change the name when you started looking at behavioral health? Did you think of that as a separate thrust within the organization? Like how did you and your team kind of conceive that?
Yeah, no, because we got all this money from NIDA really to focus on substance use disorder treatment, and we knew that it was inextricably linked to mental health, right? So we had to do both. Now, change names, change brand. No, to this day, Openbeds really doesn't describe the product and what we do end to end, the technology along with the services. But because we've created a brand around it, it's really hard to get rid of it. We talk about getting rid of it all the time, changing the name. I think the latest, idea is that we're going to add a tagline. It's not just about beds, or we're not just more than a treatment locator. But we decided to stick with the brand because of the awareness that we built around it, especially in government circles.
Mm-hmm. Can you tell us a bit how it works? How does Openbeds touch the various parts of the ecosystem?
Sure. So we sell to payers, to health systems, but right now, predominantly our customer base includes state governments, right? So we're working with 9 state governments actually, and what they do is they set up a 2-sided network with our technology and services. And so the network consists of those who refer to behavioral health in a high volume way. On the one side, hospitals, health systems, right? The courts, like I mentioned, crisis lines, mobile crisis teams. And then you've got the full spectrum of inpatient, outpatient mental health and substance use disorder treatment services on the other side. And so we help those who refer into mental health and substance use disorder treatment see availability of resources. They can use our system to get decision support regarding the right level of mental health or substance use disorder treatment. We've built decision support tools based on the ASAM criteria, for example. They can use our system to send a referral digitally, communicate back and forth, close the loop, find out whether or not their patient showed up for an intake assessment, for example. And then we track a number of metrics at the state or regional level as well as the local level around care delivery. So we look at capacity, utilization, who's referring to whom up and down the continuum of care. We look at the demographics of people being referred, paying special attention to people who are falling through the cracks, right? And why? Is it because of their payment mechanism? So that's the system in a nutshell. So as you can tell, it's much more than just availability of beds.
Right. Right, and the reporting pieces, which might be really, really difficult to get in any kind of comprehensive way, the information and analytics around it. So does this, how does the revenue piece work?
So, and then beyond that, I forgot to mention, we have a public facing system. So people in the public can peruse our treatment resources, use a decision support tool that we built with ASAM, and actually reach out to a treatment provider anonymously. So it goes beyond a treatment locator. They can say, look, hey, treatment provider, this is who I am. You know, am I appropriate for your services? So yeah, in terms of who pays for it, the model, we charge a subscription fee. The convener pays on behalf of the network. So let's say the convener is a state government. They pay on behalf of the referring organizations and the treatment organizations. And then if the convener is a payer, same thing. They pay on behalf of the network that we set up with them.
Okay. What's been the most compelling reason that you've learned about or seen that states are adopting this platform? You know, as you engage in conversations, business development, what's the piece that really makes them say, yeah, this is the solution we need?
You know, I think it's the transparency that it provides regarding capacity, regarding, like I said, who's falling through the cracks, right? What's not working? You know, these are data that state governments just haven't seen before. I'll give you an example. One of the states that we're working with, they use some of the SAMHSA dollars that they got on building more residential treatment capacity, right? They thought that they didn't have enough capacity. Well, for 12 months, week after week, we showed that they had 20 to 30% residential treatment capacity, right? That's not their problem. So they didn't spend the second tranche of funding that they got from SAMHSA on building more residential treatment capacity, even though they had planned to do so based on our data. In another state, they thought that they didn't have enough capacity related to inpatient withdrawal management, also residential treatment. And what we ended up showing week after week was that it wasn't, again, a matter of not having capacity, but there was a mismatch between how sick people were in the state, right, or are, because it's still, you know, showing up in our data. So how sick they are, and the medical services that the treatment providers were capable of providing, right? And so patient acuity or complexity of the medical conditions kept coming up as why people couldn't get into treatment. Really interesting. And so again, the state said, okay, that's what we need to target with the treatment providers. So all this to say,
and these are really
good.
Yeah, and these are really complex decision-making, resource allocation questions.
Right, right.
That you can now look at it on a systems-wide level and
That's
say,
right.
how can, everyone has some limitations, but how can we best optimize, you know, the resources you have available to serve the needs in your state?
Yeah, and we see early signals. You know, I remember 2 years ago, we started seeing an uptick in meth referrals, right? And we now know meth is it's a real problem. But, you know, looking back, there were early signals in our data around the magnitude of or what was to come in terms of the magnitude of the problem. And then in addition to that, more recently, you know, data from a few of our states show that you know, well, so I'll give you data from one of our states, shows that 30% of the referrals involve 5 or more substances, and then 20% of the referrals involve 1 substance, right? So you've got this problem of polysubstance use, and certainly federal data are in keeping with that as well. So I thought that was really interesting. I thought the data were wrong. We looked back and, you know, they weren't wrong. There was a clear signal there.
Right, that's fascinating. Right, and very different algorithms for different classes of patients and what they need.
That's exactly it. Right, right.
Yeah. So we'd love to, you know, one of the questions that comes up as a theme through this week is teams and, you know, founders, how you find founders, when you bring people in early in your journey. I noticed that a co-founder is also shares your last name, Rawat. So, you know, how did you come together in forming your founder team? And, you know, when did you decide to bring people in?
Sure. Yeah. So, I mean, he's my father. So,
I figured, but I wasn't sure.
What's that?
I figured, but I wasn't sure.
Yeah, no. So, you know, I started talking about this, and so my father's an engineer, Ph.D. electrical engineer, also background in systems engineering. So he, you know, he loves this, right? How do I make this very complicated, broken system better, right? And so he saw this as a challenge. Didn't have any medical background, behavioral health background. So I said, "Are you sure? Are you sure you want to take this on?" He was retired, and yeah, so that's how that happened. And then along the way, you know, we picked up people. They displayed an interest, and you know, we had the need for a couple of positions, obviously. And you know, if they were appropriate, we brought them on. I wouldn't say early on we were putting out job descriptions or actively looking for people. It was much more organic. People came to us either through connections, or you know, we were working out of a shared space early on, and we met people that way, and so that's how it happened. Yeah.
That's great. I mean, with COVID, you realize the co-working spaces are shifting dramatically, but there is often that challenge with, you know, you want to bring people in and you maybe need certain skill sets, but you don't have resources to pay them. So it can be a challenge, right? I mean, you had grant funding, but even so, that's a tricky piece.
Yeah, I mean, look, early on, people were paid with equity, right? Not money. And then, you know, it was even more challenging when we were acquired, who stays and who goes, right? The new company doesn't need everyone, and that's tough because you have people who have been loyal to you and to the organization, but the organization has evolved. We've evolved as a leadership team, and collectively we have different needs, so it's tough. You let people go.
Yeah. I would love to spend a few minutes on the acquisition. Can you take us back through kind of what was happening prior to the acquisition, and you know, how that all unfolded?
Yeah, so you know, it was interesting. We had previously been approached by another company. They were interested in acquiring us, and we went very far down the road with them, actually. And then they had a leadership change. It was abrupt, and then the deal fell through. And that was hard because, you know, when you're in the midst of an acquisition negotiation, it's a full-time job in and of itself, and it can be a distraction, right? So you have to choose the opportunities pretty carefully. So we felt burned by that, right? We devoted a lot of time, energy to that. And then, you know, we were doing really well. We had a couple of contracts under our belts, state contracts. We weren't looking to sell. And the president of the health unit at Appriss ended up going to a meeting that he shouldn't have been at. It was a great opportunity for us. We were presenting to 30 state representatives. They're part of the Substance Use and Justice System Coalition. And he shouldn't have been there, but he was there. And we caught wind of that afterward. I sent him an NDA saying, you know, thank you for coming, you know, or taking the opportunity to join. But we don't usually, you know, share all that information with potential competitors. And then that started the conversation. We met with them, and it was clear to me that they understood what we were doing. They understood the opportunity. They had a lot of relationships, and they started to do what we were doing because they could see the opportunity. And it felt like the right fit. You know, they were smart. It was an opportunity for us to have an impact faster. And so very quickly, they made it clear to us that they were serious about, you know, bringing us into their family. And that, you know, led to 6 months of pretty intense negotiations. Like I said, a full-time job. And then it worked out. Yeah.
So had you learned a lot in your earlier negotiation with the group with which it didn't work, which you know, ended up being invaluable to you as you were then negotiating with Appriss?
I would say yes. I mean, it's always different, right? Different people, but sure, I did learn a good amount, and I was able to apply that. Uh, but yeah, no, I learned a lot through the process the second time around as well. Yeah, yeah.
That's great. So a lot of the teams here are kind of early in their ideation phases. You know, as you look back, is there anything you might have done differently in the early phases in the substance use disorder space as you were shifting there? Is there anything that you think, oh gosh, if we had, you know, looked at this or thought about this differently?
Yeah,
Anything come to mind?
yeah, I think very early on, well, three things. I thought naively at the time that I could build this within academia, right? And I know that there are pathways to do that now within academic institutions, and certainly at Hopkins there are a lot of opportunities. But back then, it wasn't going to happen. Let's put it that way. Not at the speed that I wanted it to happen, and I think that I could have jumped earlier. I'm glad that I jumped, but I could have done that earlier. I was a little naive, maybe a lot naive. Also, I think that I thought that I could practice medicine and do this at the same time. At one point I was doing nights and weekends, shifts, nights and weekends in doing this, you know, Monday to Friday during the day. That was really hard. And that was a mistake. And I won't do that again. So those were two mistakes. And then the third one, I think that we should have seen the opportunity in the payer space earlier. I wish that we had done that. A lot of opportunity there for us now, which is great. But I didn't know enough about payers and managed care in particular to see that opportunity. And I wish that I had somehow been able to, you know, been tipped off and explored that more. Yeah.
Yeah. So when you say you left from the academic institution, you moved it out. What format did you move it into? Was it an LLC or a C corp? You know, what was the structure of that?
What I mean by that was that I was going to build the technology and establish the company, but as an academician, meaning that Hopkins, there was a team there that had offered to build the technology, and obviously I was going to give the institution a cut, but they really weren't equipped to help me build the technology. Let's put it that way at the time. And there was no tech ventures department there like there is now to really support faculty interested in starting businesses and, you know, building products. Now there's a robust system. It's awesome, right? But at the time there wasn't. And it was actually one of the IP lawyers there who said, you've spent a lot of your own time and money on this, Nishi, and you should really take this out. He was the one who convinced me, and that was good advice at the time.
And he had a good sense of really what the institution was capable of supporting.
That's exactly it. That's exactly, yeah.
Because this is a question that's really central in the minds of our cohort participants, you know, many of whom are, you know, juggling their academic careers. They know what that is. They're comfortable with that. So the risk of kind of how much to invest, when and how in their entrepreneurial journey, you know, it's a challenge. And the universities are so different in what they offer and how they offer it, because you could be in an institution that does some pieces really well, but doesn't do the piece you need to do well, right? So you might be great in therapeutics. I know Johns Hopkins is amazing there, but you know, it's very different than your innovation. So.
Right. And then, you know, I don't know how people do it, practice medicine and have a research, and have a family and build a business. You know, you hear about these people who can do it all. I tried, I failed miserably, and I had to make a choice. You know, I had to stop working clinically. I'm going to go back. I look forward to going back, but it's just not it's just, it wasn't possible for me, and it's not possible right now.
Yeah.
Yeah.
So I'd love to open it up to Nishi. If you have a few more minutes, I'd love to open this up. If our participants have any questions for you, you can just unmute and ask if you'd like, or you could type it into the chat as well.
I'd like to take a shot. Janie, those were excellent questions. Every single one of them were amazing, and the responses were great. Just to build on that, I wonder, in this kind of transition from being an academician and filling in the kind of social purpose, like nonprofit social purpose kind of research, any thoughts or lessons in how to kind of how do you kind of somewhat transcend or transform your thinking, the way you're seeing things, to a kind of product-driven, for-profit mindset?
So interesting. Yeah, that was a real transition, and that transition happened over time without me realizing that there was a transition in terms of my mindset, like you said, in that I was very focused on doing good, having impact, right? Showing results in a very sort of research rigorous way, right? When I kept getting feedback that all that mattered was revenue, right? I just had to make money. And if I made money, everything else will become easy. And I think it was just that constant feedback that, that's what mattered, right? To investors. Ultimately, that was the most important measure of success, right? And in addition to that, I needed money to subsist, to pay people, right? So that's how my mindset shifted over time. But even to this day, with Appriss, I'm not all the way there yet, right? My colleagues, Brad, who's the SVP for Biz Dev, and Rob, the president of the business unit, they think differently than I do. And I'm not saying that the way I think is bad, but I don't think the way they do. I definitely have a clinician mindset, and that's not going to go away. Yeah.
And
so I don't know if that was helpful. Yeah.
When did that happen?
Right.
Happen?
So what happened was I realized that I didn't know enough, right? And I was tired of taking, one step forward and then 8 steps back, because I didn't have the business background. And I didn't like the fact that I had to rely on other people to provide that expertise. And so, I was crazy, and I went ahead and I got my MBA at Georgetown in the midst of this. What was neat was that at the time we were being acquired, I was going through my MBA, and I was literally able to apply a lot of what I was learning, finance especially, in that realm, to the acquisition process. But that's why I went ahead and did that. I don't think that everyone needs that. I just needed. I needed to learn. I learned in a certain way. What's that?
Other than the finance piece, do you think you learned anything relevant in the MBA program?
Yes, accounting, finance. Let's see. Economics, right? I've got a very, a pure science background. I don't know anything. I didn't know anything about macro, microeconomics. I know kids these days take those courses in high school. I didn't, right? So I think those were important courses for me. Negotiations, really, really important. Yeah. So, but I did do a lot of finance courses within the MBA, and those really helped me, I would say. But again, that's because I learned in a certain way. I need that structured curriculum to be able to learn. I think that 75% of people don't need to do that, and could learn it on the fly.
So Janie, we have a few pretty interesting questions in the chat. So I don't know if you can.
Yep. So I'll ask these to Nishi. In terms of NDAs, one of them was when did you ask for an NDA? So you mentioned when you realized you were talking in a conversation in which a competitor was there, but typically when would you trigger asking for that?
Up front, all the time.
All the time.
Yeah, nobody's insulted by it. Yeah. After a first phone conversation, before any demonstration, yeah, NDA.
Great.
Yeah.
And what about, how did you decide to take on bigger partners, and how, were you able to retain control? That was the question. How do you decide when to take on bigger partners, and is it possible to retain control?
Do you mean in the midst of the acquisition, retaining control?
I think so. Yep, I think so.
Yeah, it's tough. So you have to acquiesce control. A lot of these acquisitions don't work out well, right? People are promised a certain set of resources, or they're promised that things are going to go one way and they don't. And we were very lucky. Rob acquired us, or the Appriss acquired us as a wholly owned subsidiary. I was left with a lot of control. They integrated us over time with my comfort level. I mean, it worked out well. But we did put a lot of this in the contract up front, which helps, right? So attention to detail, making sure that all the gaps are filled in that agreement, thinking of everything as much as you can up front really, really helps.
Right. It's setting the right kind of bearing and footing for everyone to say, this is what I want from this relationship, and this is how I want this to look, and having those hard conversations early.
That's right. That's right. And what's neat is that it brings you closer together. Having those hard conversations early, it's tough. You don't know one another, but by having those hard conversations and duking it out to a certain extent, you get to know one another very well, and you build a certain amount of trust as well.
Right. And if it's totally unaligned, you can walk away.
Right.
So let's take the last question, Janie, and then we'll wrap up to move on to reflections. Seth is thrilled to get into reflections. He gets the spotlight yet again. So
I have a mirror right here.
This question was on, the serendipity of you at a pitch contest that NIDA was there. The NIDA team is incredibly entrepreneurial, speaking of entrepreneurs. But,
nice.
One question was, how did you pick and choose your pitching and presenting opportunities in the early phase, especially if it sounds like you didn't really love to do it?
Well, I just thought that people who were focused on these pitches, they were focused on promoting themselves as opposed to building their business. I mean, that was my mindset at the time, and I didn't have time. I was working clinically, trying to build a business, right? I didn't have time to prepare for these things, and it was because the reason I did this one was because it was our co-working space, 1776. I don't know if you're familiar with them. They no longer really exist, but at the time they were a big deal in DC, and actually nationally, they built this beautiful brand around themselves, and they were holding a startup contest in every city in the US, every major city, and then also internationally, worldwide. And so they wanted me to compete in the DC one. I was working a night shift. So they said, look, just go to New York and do it. Went to New York, wasn't prepared, won. We won. And so that that meant that we were then presenting at the international one, the meeting or the startup competition, which was being held in DC. So that was convenient. And that's how I ended up on the stage in DC, and they were in the crowd. And so, yeah, I talk about, well, maybe it's not worth your time doing these things, but that was worth my time. We were at the right place at the right time. And you're absolutely right. They set us on this different path. Yeah. So there's a balance. I guess you should do some of these things, right?
Yeah.
Yeah.
Right. Well, chance favors they're prepared, right?
So, Nishi, one last question.
Thank you so much.
Start to finish, how many years have you been at this?
Yeah. So I would say started thinking about this, building the product in late 2014, and then incorporated the company in 2015, just because I had to get my green card before I could do that. And then acquired in 2018. It was really quick, September of 2018.
Was it a cash acquisition, stock?
It was cash.
Cash acquisition, earnout, no earnout?
With earnout.
Yeah, by the way, you see like clinicians, researchers, they don't talk about money. Like, gotta get comfortable talking about money.
Yeah, of course.
If you're going to do this, right? So did you say no earnout?
Yes, earnout, absolutely.
There was an earnout.
Yeah.
You have a pretty senior role at the company now. That company's been around a long time, right?
That's right. Over 20
The
years.
addiction space was a big pivot for them, big growth area. They sort of had these other contracts.
Yeah, they're a 1,000-person company, 3 business units, safety, retail, and health. So I'm in the health unit, and yeah, I report to the president of the health unit. It's been,
And
you
how
know,
much
I
money,
go ahead.
how much money went into the company before you sold it?
So I've got to think back. Did I personally put in, or
How much was invested into the company, and then how much did NIDA bring to the table?
so dollars or my time, resources, team's time?
Let's just say
Yeah.
outside dollars. Let's assume we all get screwed with our sweat equity.
Yeah. Okay. So I've got to think back how much of the NIDA money we had spent by that time. It wasn't a lot. So I would say probably in the order of about 300 grand.
From NIDA, and the rest of it was bootstrap, no outside capital?
Yeah.
Okay.
Yeah, no outside capital. We had been looking to do a Series A at the time we got the money from NIDA. So we had actually been pitching to investors and then ended up getting the money from NIDA and then didn't need to raise money in the end.
Were you profitable when you sold?
We were, but that was because we were really lean, and we ended up winning. We ended up winning a couple of contracts, right? And we had the grant money.
Yeah.
So yeah.
Great. Thank you very much. It's great.
Of course. And
Yeah.
yeah, feel free to reach out to me if you have my contact information. I'm happy to, chat with any of you by email or phone, whatever you'd like. Like I said, I made a lot of mistakes, and if I can help anyone not make those same mistakes, I'd love to do that. Yeah.
Thank you. That's so generous and so gracious. And thank you so much for speaking with us today, and have a great day.
Yeah,
and
absolutely.
everyone else, I want you to stay put, because we will have reflections on today with Seth and Patricia.
Yeah, Patricia, it sounds like you want me to go. I can go.
Yeah, I do. Yeah, go ahead, Seth. Go ahead.
Well, I think my questions for Nishi were really kind of the point. I mean, for me, like her story, and we're going to try to do this every day, at least have some